Bismillah ar-Rahman ar-Rahim. First of all, I'm really thankful to Pakistan Cardiac Society who started this webinar series. It's the first one among all the next series which has to come. It's really a great opportunity for me and for all the people who join and who learn from this forum. It's really difficult for me to talk in front of my esteemed teachers and the great teachers who are specialists in this preventive field. Today we'll be talking about primary prevention of cardiovascular disease in relevance to Pakistan. So I want to start with this, want you to look at this cartoon, that how many risk factors can you spot in this cartoon? A fat man sitting on the chair with a glass of wine and smoking. What he thinks that not much, I'm just flushing out my arteries. But we all do think like this, or we all think differently. Let's see and talk about prevention. So the first thing we need to know is the cardiovascular health. The ACC and AHA defines cardiovascular health, and we divide it into two categories. One is health behaviors, and the other comes under the umbrella of health factors. Among the health behaviors, it's the healthy diet, physical activity, abstinence from tobacco, and a normal BMI. These are health behaviors, and the health factors are the favorable blood pressure, your total cholesterol, and your glucose level. All these are the health factors which are defined by the AHA as part of the cardiovascular health. So atherosclerotic cardiovascular disease, it's the leading cause of morbidity and mortality around the globe. And it's responsible for 1/3 of all deaths worldwide. That is about 17.9 million people each year. And the interesting thing is that 85% of all these deaths are due to heart attacks and stroke. And the one which is more alarming situation is that more than 75% of these deaths are in the low and middle income countries. So we need to worry about it more as compared to the high income countries. And we'll look into it in a bit detail in this slide, that if you see in the high income countries, it's the cancer which is the leading cause of death. While in the middle and low income countries, it's the cardiovascular disease in red, which is the cause of major cause of death in middle and low income countries. So we need to worry more about the atherosclerotic cardiovascular disease as compared to other diseases. When we talk about prevention, we divide prevention into three categories or three different approaches. That is primordial prevention, primary prevention, and secondary prevention. The primordial prevention is related more to health behaviors. The primary prevention focuses on the risk factors, and the secondary prevention comes into play when you already have the cardiovascular disease. So the primordial prevention starts from the childhood. Smoking, high caloric diet, the body weight, and environmental pollution all comes under the umbrella of primordial prevention. While the primary prevention, the risk factors are dyslipidemia, hypertension, diabetes, and metabolic syndrome. And definitely the cardiovascular diseases which need secondary prevention are the coronary heart disease, cerebrovascular, peripheral vascular, and heart failure. These are the ABCs of primary prevention. And you can say this slide is an overview of today's presentation. We will cover all these ABCs of prevention in today's presentation, in which A is for the risk assessment and aspirin, B is for blood pressure, C is for cholesterol and cigarettes, D is for diet, weight, and diabetes, and E is for exercise. We will discuss each and every one of them turn by turn. But before that, we need to know about the ASCVD risk calculator. It's available online, it's available in the mobile apps, and I wish every physician should have it in his mobile to calculate the ASCVD risk for for the not only the patients, but for those who wish to know about their ASCVD risk. And we divide patients into different groups on the basis of the 10 years risk of ASCVD when we use the ASCVD risk calculator. And if the 10-year risk is less than 5%, this is considered as low risk. While less than 7.5, from 5 to 7.4% are considered to be at borderline, and from 7.5 to less than 20%, they are at intermediate risk for the ASCVD. While anything 20% or more than that, these are the people who are at high risk for ASCVD. So ASCVD risk calculator defines all these groups for us. Let's have a look at some scenarios. This is our day-to-day routine life. We come across these scenarios. We come across these in our OPDs, in our day-to-day life. That one of your family member who is 47 years old with no comorbids and does exercise regularly is concerned about his health and asks you that, do I need to worry about my risk for cardiovascular disease? Or he asks, what should I do for the prevention of cardiovascular diseases? Another 62 years old retired teacher walks into your clinic and said that my primary physician has calculated the 10 years ASCVD risk for me, and it turned out to be 12.5%. Now somebody has told him about aspirin. He asks you, should I start aspirin for prevention of cardiovascular disease or not? So almost every patient in your OPD asks you about the diet plan, and they are very much concerned about it. As a cardiologist, we need to have an idea about the diet plan for our patients, especially for the prevention. So another very important question being asked by the patient is about exercise. Yes, they do ask how much I should do, what intensity of exercise am I supposed to do? Another patient who is 56-year-old with diabetes, will you start him on statin therapy or not? This is about statin. We need to know about the statins. And should we use the coronary artery calcium score to know about the risk of patients for cardiovascular disease, or we should not use it? Let's talk about each and every aspect of this primary prevention. The first thing is assessment of cardiovascular risk, because a heart health assessment can save your life. So the ACC-AHA recommends that adults with 40 to 75 years of age should be routinely assessed for the ASCVD risk, for the 10 years ASCVD risk. And those who are 20 to 39 years of age, they may be assessed for the traditional ASCVD risk at least every 4 to 6 years. While those adults who are at borderline risk or at intermediate, mean less than 20%, so they are not going about 20%, less than 20%, you need to look for the additional risk-enhancing factors in these patients. And these risk-enhancing, we will talk about it in a short while. These risk-enhancing factors will guide your decision about preventive intervention, whether you want to give statin therapy to these patients or not. So you need to look for the additional risk-enhancing factors in all those who are having their ASCVD risk of less than 20%. So again, those at intermediate and borderline risk, and you do not reach a decision about the preventive intervention, they remain uncertain. These are the patients in which you may go for the coronary artery calcium score to guide the clinician-patient risk discussion. So it's not for screening, but if still they are at borderline risk, they are at intermediate risk, and still you do not reach a decision about the preventive measures, you need to measure the calcium, the coronary artery calcium score. So these are the risk-enhancing factors. Any patient with family history of premature ASCVD, that for males is less than 55 years and for females is less than 65 years. This enhances the risk of ASCVD. and the primary hypercholesterolemia. Remember one thing about the primary hypercholesterolemia. If you get a patient with primary hypercholesterolemia, no calculator is applied to this subgroup of patients. They are at high risk, they are considered, you do not need to calculate the risk for these patients. They are at high risk and you need to start these patients on statins and preventive measures. The other risk-enhancing factors are the metabolic syndrome, chronic kidney disease, and chronic inflammatory conditions. All these enhances the risk of ASCVD. In women, premature menopause and preeclampsia, and the high-risk race and ethnicity, the South Asian ancestry, again, very alarming, that this carries a high risk. They are one enhancing factor for the ASCVD. The lipid biomarkers, those with primary hypertriglyceridemia of more than 175 milligram per deciliters, and other things like CRP levels, the LP little a, of more than 50 milligram per deciliters, they are at higher risk. And the LP little a is going to make its position more and more in the upcoming guidelines. The apolipoprotein B, if in those patients who have a triglyceride of more than 200 milligram per deciliters, so a level of 130 corresponds to LDL-C of more than 160, and this constitutes a risk-enhancing factor. So those with hypertriglyceridemia, you measure apolipoprotein B and it's more than 130, this is a high-risk factor. And definitely the Inkel-Baker index of less than 0.9 is a risk-enhancing factor. So let's talk about nutrition and diet. And we all do like this. We want to start eating healthy, but we want to treat ourselves one last time because we deserve it for this time. And we want to start it from tomorrow, and that tomorrow never comes. Let's see how nutrition is important. The AACC recommends that a diet emphasizing intake of vegetables, fruits, legumes, nuts, whole grains, and fish. These are class 1. And the important other thing, the fats, the saturated fat and unsaturated fat. You need to replace saturated fat with unsaturated fat. And you can recognize the saturated fats are those who remain solid at room temperature, while the unsaturated fats are those who remain liquid at room temperature. Saturated means just all the carbons are being saturated with hydrogen, and unsaturated when not all the carbons are being saturated with hydrogen ions. So replacement of saturated fat with unsaturated fat is beneficial to reduce the ASCVD risk. And a diet containing reduced amounts of cholesterol and sodium can be beneficial to decrease the ASCVD risk. So regarding the processed meats, refined carbohydrates, and sweetened beverages, they need to be minimized. Their intake need to be minimized if you want to reduce the ASCVD risk. And one unsaturated fats are beneficial, but one unsaturated fat, that is trans fats, which comes like margarine, they're like butter, but they're not butter. They are not recommended and they must be avoided. This is class 3 harm. This is just to give you an overview of the diet plan. Those who are protective foods, the food which can be eaten in moderation, and the food which needs to be avoided, like refined grains, starches, sugar, salt, processed meats, and industrial trans fat. All these needs to be avoided. A few more words about nutrition, because I think it's more important regarding the animal protein versus plant protein. When you compare plant protein and animal protein, in one study they showed that using meat for protein is associated with a 61% increase in mortality rate. So you take your proteins from meat, you increase your mortality by 61%. And if you replace meat with nuts and seeds, you reduce the mortality by 40%, and that's quite significant. So replacement, other studies show replacement of animal protein with plant protein is associated with reduced cardiovascular mortality, and it's further been classified. If you compare the plant with the plant protein, the poultry and fish gives you a 6% higher mortality if you compare it with plant protein. The dairy products, they give you 8% higher mortality, while the unprocessed red meat gives you a 12%, eggs give you 19%, and the processed red meat gives you 34% higher mortality as compared to the plant protein. So you need to get your proteins from the plant sources as compared to the animal sources. Exercise and physical activity. We all need to feel the burn. If you do not feel the burn, it's very difficult to do exercise. So this is an important thing, and you need to feel the burn. All adults should be routinely counseled. You need to consult each and every patient, each and every adults who come for the healthcare visits. You need to counsel them about the physically active lifestyle. And what are the recommendations? How much exercise should be done? This is at least 150 minutes per week of moderate intensity, or the 75 minutes per week of vigorous intensity aerobic physical activity. This is what the ASC and the ACC recommends if you want to reduce the ASCVD risk. This is class 1. But the story doesn't end here. If a patient is unable to meet this minimum requirement, this 150 minutes of moderate and 75 minutes of vigorous, engaging in some moderate or vigorous intensity, this can be beneficial. You can do something to do a physical activity. This can be beneficial. Or if a patient even doesn't do this, at least the class 2B is you decrease the sedentary behavior in adults. That may be reasonable to reduce, that may reduce the ASCVD risk in patients. So you have to counsel them to do at least some activity, some physical activity, and reduce the sedentary behavior. And sedentary behavior is definitely that's gonna give you less than 1.5 minutes, like sitting and reclining. And those who give you up to 2.9 minutes, this is a light physical activity, like walking slowly and cooking. Those who give you up to 5.9 minutes are the moderate physical activity, brisk walking and biking. Those which give you more than 6 minutes, like jogging and running and biking at higher speed, this is a vigorous physical activity. So for vigorous physical activity, 75 minutes per week is recommended. And for moderate physical activity, it's 150 minutes per week is recommended. Let's talk about overweight and obesity. We all should be worried about the weight and obesity. And the important thing is, in all the people who are overweight and obese, weight loss, you need to counsel them to lose weight. If you want to improve the ASCVD risk factor profile, you do not have to ignore this. You have to lose weight. And comprehensive counseling and comprehensive lifestyle interventions that also include calorie restriction that is recommended for achieving and maintaining weight loss who are overweight and obese. So you need to counsel them, you need to do lifestyle intervention, you need to do calorie restriction in all these patients to lose weight. You need to calculate BMI annually or even more frequently to identify. The first thing is to identify people who are overweight. So for that, you need to calculate the BMI. Those who are overweight and obese, so then you consider weight loss. And waist circumference is another thing which may be reasonable to identify those at a higher cardiometabolic risk. So BMI and waist circumference, all these two need to be measured. Type 2 diabetes mellitus, and it's definitely something right behind you if you're walking on a rope like this. So a diabetic patient lives his average day like this. So for all type 2 diabetic patients, you need to have a dietary pattern, and their dietary pattern is recommended to improve two things: improve glycemic control and achieve weight loss if needed. If they are overweight or obese, you need to improve the glycemic control and achieve a weight loss as well. And those who are diabetic, definitely the recommendation for physical activity is there. And again, 150 minutes of moderate and 75 minutes of vigorous intensity physical activity. And this is meant to achieve a glycemic control and weight loss if needed, if they are obese. So you need to achieve the glycemic control and weight loss if you want to improve the ASCVD risk factor in these patients. For type 2 diabetes, the ACC recommends to initiate metformin as a first-line therapy along with lifestyle therapies at the time of diagnosis to improve glycemic control. Metformin is the first line, and those who require glucose lowering therapy despite initial lifestyle modification and metformin, you have given lifestyle modifications and metformin, still they need further therapy. There comes the SGLT2 inhibitor and GLP-1 agonist. You need to give these to these patients to improve glycemic control and reduce the cardiovascular disease risk. The blood cholesterol, another very important thing in primary prevention is, sorry. So those patients, those elders who are at intermediate risk, mean their risk is CVD risk is less than 20%. You need to start these patients on statins. Less than 20%, from 7.5 to 20%. You need to start these patients on statin, and the recommended is the moderate intensity statin in these patients. And for those who are again at intermediate risk, you need to reduce the LDL-C levels. So for intermediate risk patients, you start on moderate intensity statins, and you need to reduce the LDL-C level by 30% or more from the baseline. And those who are at high risk, mean the ASCVD is more than 20%, you need to reduce the levels by 50% or more. So this should be the target of giving statin therapy to these patients. Those with diabetes and the age is 40 to 75 years, you do not consider the 10-year ASCVD risk. Give moderate intensity statin therapy to these patients. So diabetic patients need to be given moderate intensity statins regardless of their 10-year ASCVD risk. And in patients with 20 to 75 years, now there comes the hypercholesterolemia. In hypercholesterolemia like this, the LDL-C levels of 190, you need to give the maximally tolerated statin therapy. You go to the maximum they can tolerate. The statin therapy is recommended, and it's class 1 recommendation for these patients. So the patients with diabetes who have other ASCVD risk factors, you can go for the high intensity statin therapy, and the goal here goes up to the 50% reduction in the LDL-C levels. And those at intermediate risk, less than 20%, you need to consider risk enhancing factors that if the presence of these factors will favor initiation or intensification of statin therapy. In patients with intermediate risk, we talked about the coronary artery calcium score. You need to reach a decision about, and that remains uncertain. You need to measure the coronary artery calcium score. So when you measure the coronary artery calcium score and that turns out to be 0, you can withhold statin therapy and reassess in 5 to 10 years. If there are other high-risk conditions present, like diabetes and family history of premature cigarette smoking, you can consider, but if these are absent, you need to withhold statin therapy. While those who are having calcium score of 1 to 99, you may initiate statin therapy for patients who are specifically more than 55 years of age. And if the calcium score is 100 or higher, it is reasonable again to initiate statin therapy in these patients. In patients with borderline risk, now there comes those who are less than 7.5%, the presence of risk-enhancing factors need to be considered in these patients. And if they are present, a moderate intensity statin therapy is justified to be initiated in these patients. Coronary artery calcium score can be measured in all those patients, and this gives benefit when you measure it in patients who are reluctant to initiate statin and they wish to understand their risk. I do not know whether I will get benefit from the statins or not. So you measure the coronary artery calcium score. Patients who are concerned about the need to reinstitute statin therapy, you discontinue it and you want to restart it, and the patient is concerned whether I will get benefit of it or not, you go for the coronary artery calcium score measurement. Older patients like 55 to 18 male and 60 to 18 women, who are having low burden of risk factors, who question whether they would benefit from statin therapy, they are still not convinced that they will benefit from statin therapy or not, you go for the calcium score measurement in these patients, and that is going to tell you whether this particular patient will benefit or not. The middle-aged adults with the 10-year ASCVD risk of 5 to less than 7.5%, with other factors that increase the ASCVD risk, and they are at borderline. So the risk is less than 7.5. They have other factors, but they are not intermediate. You need to further decide whether statin therapy will help these patients or not. So you measure the coronary artery calcium score in these patients. Hypertension, another very important thing need to be considered in primary prevention. And those people who are having elevated blood pressure or hypertension, they require antihypertensive medications along with the non-pharmacological interventions. The non-pharmacological interventions are recommended to reduce blood pressure. And these include weight loss, a heart-healthy dietary pattern, sodium reduction, dietary potassium supplementation, physical activity with a structured exercise program, limited alcohol. So all these non-pharmacological interventions are class 1 in all those patients who are having elevated blood pressure. Now, here comes the 10-year ASCVD risk of 10%. So 10-year risk, 10% or higher. And their blood pressure is having systolic of 130 or more, or a diastolic of 80 or more. You need to start these patients on BP lowering medications for the primary prevention of cardiovascular disease. So you measure the ASCVD risk, you measure the blood pressure. ASCVD risk is 10% or more, blood pressure is 130 or more, and diastolic of 80 or more, you need to start these patients on medications. Those with confirmed hypertension, again, the 10 years risk is higher than 10%. You need to target blood pressure of less than 130 in these and in those patients with chronic kidney disease. Both are class 1. So with hypertension, they are having 10 years risk, and hypertension with chronic kidney disease, the target blood pressure should be less than 130 by 80 to improve their cardiovascular risk. So in adults with confirmed hypertension without additional markers of increased ASCVD risk, a BP target of less than 130 by 80 may be reasonable. So they do not have additional markers or of increased ASCVD risk. The target now here is 2B if you achieve it 130 by 80. Tobacco use. So when you light a cigarette, your life burns with it. This is the message we need to communicate to all those who use tobacco. And the first thing is assessment. You need to assess your patients on their every healthcare visit for tobacco use and their tobacco use status to be recorded. And how do you record it? You ask the patient. If the patient has used tobacco, even a single puff in the last 30 days, this person is considered as a current smoker. Even a single use of tobacco in any other forms in the last 30 days, this is a current smoker, not a past smoker. So achieve tobacco abstinence. All adults need to be firmly advised to quit. Your advice to these patients matters a lot. In adults who use tobacco, a combination of behavioral intervention plus pharmacotherapy is recommended. This is also class 1. You need to do behavioral intervention. You need to give pharmacotherapy to these patients to reduce the ASCVD risk in these patients. And those who use tobacco, abstinence is recommended. Abstinence. You need to stop their smoking behavior. And this is going to reduce their ASCVD risk. To facilitate the cessation, every healthcare facility need to have a dedicated trained staff who advise patients and help patients in tobacco treatment and tobacco abstinence. Every healthcare facility need to have a dedicated trained staff, and all adults and adolescents should avoid secondhand smoke. This is harm. Even the secondhand smoke, it increases the ASCVD risk. So to reduce your risk, you need to avoid the secondhand smoke as well. Let's talk about aspirin use. Which are the patients we need to give aspirin? The low dose aspirin, 75 to 100 milligram, it can be considered. Let's see, this is class 2B. It can be considered for the primary prevention those who are 40 to 70 years of age and a higher ASCVD risk. Mean the ASCVD risk is more than 20%. The age is 40 to 70 years. But remember, they should not be at increased bleeding risk. These are the patients who can be considered for the low-dose aspirin for the primary prevention of cardiovascular ASCVD risk. And those who are adults more than 70 years of age, on routine basis giving aspirin to these patients, this is not recommended. And those who are having any age but at increased risk of bleeding, you again do not give aspirin to these patients. So aspirin to only the top group who are having 40 to 70 years age and a higher ASCVD risk, more than 20%, but they should not be at increased. This is the only recommendation, and that again is 2B. For all others, routine basis, or they are at increased risk of bleeding, you do not need to give aspirin to these patients for the primary prevention purpose. Now, what are the take-home message from today's presentation? So, the leading cause of morbidity and mortality, lots of resources are spent on the healthcare services and medications of ASCVD. We treat a lot of them, and you know, the suboptimal prevention and risk factor modification is the cause for much of this. So most of the resources are being utilized because we do not have optimal prevention and risk factor modification for our patients, for our population. The most important way of prevention is to promote a heart-healthy lifestyle. So this is the key for the prevention, and a team-based care approach is an effective way of prevention. The use of aspirin should be infrequent because of lack of evidence. You should not give aspirin to each and every patient. Statin therapy is first line in patients with diabetic and raised LDL-C of more than 190 milligram per deciliter. While the non-pharmacological interventions are recommended for adults with elevated blood pressure or hypertension. Thank you very much. Thanks a lot. Thanks for patience listening.
Well done, Samiullah. It's a very nice, calculated presentation on a very broad topic of prevention. and specifically in primary prevention. वो कहते हैं ना कि आपने समंदर को कूजी में बंद कर दिया है, माशाल्लाह. So I'm opening the session for discussion, the panelists, and we will also ask some of the questions from the speaker being put by the attendant and the audience.
I think we should go first for the question, then meanwhile we will be giving.
So there's a question, Samiullah, that one of the participant asked, is a CBD risk calculation is necessary for young female as well?
Samiullah, I just request you if you can just stop sharing your screen, then
Okay, sir.
all
Okay, sir.
people will be more on the. Yeah. Now you can answer.
So for the calculation of ASCVD risk, the age limit is 40 to 70 years.
It's
All those who are at the age of 40 to 70 years, you need to assess these patients, these people for the ASCVD risk. While those at 20 to 39, for 20 to 39, they can be assessed not to routine, not yearly, not routine, but every 4 to 6 years.
Sami, actually the question was regarding sex in relation to females. So I think it's irrespective of sex, you have to calculate risk even in.
Yes. So another question is, what is
Can I
those
add something here?
Yes, sir. Sure.
Okay. So there is a new calculator which we should all be aware of. So AHA had introduced a new calculator in their November meeting. It's called Prevent, PREVENT. And its app is now also available online, so you can use that. The difference between what was shown here, AHA calculator, from Prevent is one, age doesn't start from 40, it starts from 30. So younger age is included in this. Second very important thing is that the ACC AHA calculator, risk calculator at this time, does not calculate the risk for South Asian ancestry. They clearly say if you have non-Hispanic or non-Caucasian ancestry, then the risk is not accurately calculated. Whereas Prevent is for global calculation. It includes all racial ancestry. So even South Asian ancestry is also included in that. In the calculation, it doesn't take into account LDL. It takes into account total cholesterol and HDL, and calculates non-HDL cholesterol, which is a much better way of risk calculation as far as lipids is concerned, rather than apolipo B1A ratio, which is not available commercially anywhere in the world, also in the Pakistan. So that is as far as the risk calculation is concerned.
Should we start statin to every diabetic patient irrespective of LDL levels?
I think we just talked about it. The diabetic patients, they need to be started on statin therapy, irrespective of their risk for ASCVD.
So another question is probably for our Kazmi Saab, and it is from Professor Dr. Bilal Mahiuddin, that what are the national trends in Pakistan?
We can switch these questions to panelists as well.
Bilal Saab? Yeah, this is from the panelist. That what are the national trends of treatment and diet in Pakistan?
I don't know whether the question was directly directed to me or not, but anyway, I think as far as the presentation is concerned, I mean, I think just a little comment. I mean, it was a very good presentation, very thorough, as far as the ACC-AHA risk calculator is concerned. But I think a couple of things which probably we could have added, and that would have kind of be even more relevant. One, I think there are other risk calculators also, so we would like to see which one you want to use. I mean, why not WHO risk calculator? Why not ESC risk calculator, and so on and so forth. I talked about prevent anyway. Second is very important thing, relevance to Pakistan. So the title said, I mean, primary risk prevention in relevance to Pakistan. So I think that's something which is a debate which I think it hasn't been touched upon, and we may need to have a discussion here with the panel, I think, and that's what Bilal was probably mentioned. When you change guidelines, I mean, when do you need, I mean, I think if you have international guidelines for anything, do you have to have your local guidelines or not? So there are, I think, two important factors which you need to see. One, whether your disease pattern is different or not. And that comes from data. Unfortunately, we do not have robust data for Pakistan in the majority of the situations as far as cardiovascular disease is concerned. So we end up saying that we don't have any evidence whether we are any different or not different. So that's a deficiency we have. So until at that time, we probably have to just be using the international guidelines which we have. Second is the point whether there are socioeconomic or social differences in your situation. And I think that is a very, very important question which we need to be asking. Well, definitely our socioeconomic situation is very different compared to for where the guidelines are meant for. I mean, ESC guidelines are for only European countries. ACC-AHA guidelines are only for American citizens or American area. So we have a very different situation. So we need to talk about that, what is primary prevention? How do you really go to the communities to have primary prevention, and whether statin is a viable therapy as far as the economic situation is concerned. Again, unfortunately, we do not have any cost-effective analysis on saying that, I mean, statin would cost this much, but it would save this much. We feel that that's, yes, in a Western situation, statin is a very, very cost-effective strategy because it saves a lot of cost in the illness, in the dailies, in the hospitalization, and then mortality and the associated other situations. So as far as Pakistan is concerned, our diet is, which Bilal was asking, is a very, very big area where we have not really done any homework as far as we need to do that, how we would be talking to people about changing diets, what strategies we need to do. In general, our diet, the way we cook our food, the way we use what we use is certainly raises a lot of question as far as our health promotion is concerned.
Thank you, sir.
So your comments, sir, your comments, just Rauf, want to add to Dr. Khawar's comments, because it brought two responsibilities for Dr. Khawar as chairman Scientific Committee for Prevention. One is to make a mode to get data across the country regarding the preventive. Anyway, just a brief format or forms so that we can collect something about it, that we always curse ourselves, we don't have data. Second, this is a long-term plan. Second, I would suggest Dr. Khawar to incorporate multiple calculators, and whichever is more relevant to our population, just come up with that, and that will start propagating at least till we don't have enough data. Yes, over to Rauf.
Yes,
If Dr. Power
sir,
wants to respond.
We have short of time, just 9 minutes remaining. So we are taking just 2 questions. One is regarding PCSK9, and it was directly asked from Dr. Fawad Seb. Although I have the intention that the next question will go to Fawad Seb. So what is the shed some light on PCSK9?
I think today's discussion was primary prevention, but even PCSK9 can have a role of that in familial dyslipidemia, where you have exuberant, a very high level of like LDLs, as Sami already narrated in his talk, that in those you don't have to calculate risk, they're already at very high risk. And most of the guidelines are suggesting their target at least 100 LDL, whatever if they're more than 190 baseline, at least you should be achieving 100 LDL. And that I personally believe, and it's very difficult to achieve with maximum doses of statin and even with combination of ezetimibe. So you may need PCSK9 at that stage, and luckily we are going to have it in this year, this PCSK9 in our country. So that's one question Rauf is missing. You can ask anyone regarding potassium dosages as a supplement to prevent hypertension.
Yes, that I was going for Madam Amber about because she is much
He's a specialist of
involved
potassium.
in potassium, hypertension. She's working a lot in hypertension. So, ma'am, this question, ma'am, are you here?
जी मैं यहाँ पे हूँ जी
हमेशा मुश्किल क्वेश्चन आपकी तरफ होता है तो यहाँ पे क्वेश्चन है कि पोटेशियम के लेवल है उसमें क्योंकि सोडियम पे तो बात होती है हाइपरटेंशन में कि उस प्रिवेंशन में कुछ उसका किरदार है पोटेशियम का
Thank you, Rauf. First of all, I really want to congratulate Pakistan Cardiac Society and especially the KPK chapter who have this innovation of this type of a webinar. This is the need of the day. And secondly, a very nice topic been selected. And as we know, prevention is really a need of the day. और इस पे जितना भी काम किया जाए वो कम है दैट्स नॉट ओनली कि हम सेकेंडरी प्रिवेंशन पे सब लोग आजकल बहुत काम कर रहे हैं लेकिन प्राइमरी प्रिवेंशन एंड प्रिमोडियल प्रिवेंशन जैसे अभी समी ने जिक्र किया और खबर काज़मी साहब तो मेरा ख्याल है पिछले 10-15 साल से हमें इन तमाम चीज़ों के मुतालिक बता रहे हैं सेंसिटाइज कर रहे हैं और ये जो आपने क्वेश्चन पूछा है ये भी अगर हम देखें बेसिकली तो जैसे हम डायबिटीज पे बात कर रहे हैं डाइट पे बात कर रहे हैं साथ में एक्सरसाइज क्विट स्मोकिंग फीमेल्स और मेल्स सेक्स डिफरेंस सोशो इकोनॉमिक कंडीशन द सेम इज द हाइपरटेंशन और as we all know hypertension is the silent killer and we must have to identify the risk factors and especially the dietary things जो कि हमारे साउथ एशियन में एंड स्पेशली पाकिस्तान में इस खाने पीने का तरीका टोटली डिफरेंट है और इस चीज में वी मस्ट ऑल अंडरस्टैंड इट्स वेरी इम्पोर्टेंट कि वी शुड आइडेंटिफाई कि whether this is a primary hypertensive है या secondary hypertensive causes हैं उसके हिसाब से हमें देखना है कि वो कौन सी एंटी हाइपरटेंसिव ड्रग्स ले रहे हैं उसके साथ इंडिविजुअल पेशेंट को टेलर्ड करना है और वहाँ पे वी मस्ट नो अबाउट देयर इलेक्ट्रोलाइट्स एज वेल एज देयर पोटेशियम लेवल्स एंड वी मस्ट नो कि कौन से डाइट्स हैं जहाँ से हमें पोटेशियम सप्लीमेंट्स मिल सकते हैं और पेशेंट्स को और इन सबको ये बात समझाना इतना मुश्किल है कि पोटेशियम के अच्छे सोर्सेस क्या हैं केला खा लो तो मेरा सीना खराब हो रहा है खजूर खा लो तो ये हो रहा है सो इट इज वेरी डिफिकल्ट एंड बेसिकली वी मस्ट हैव अ प्रॉपर न्यूट्रिशनिस्ट इन एवरी कार्डियोलॉजी डिपार्टमेंट who should be well trained regarding this nutritional behavioral change in our community and it will definitely help us out regarding this.
Thank you,
Thank you very much.
Can I add something
and
here again? I think it's probably
yes
going
sir,
to take.
आप करिए, फिर
Sure.
इंशाल्लाह प्रेसिडेंट साहब जो है वो
जी
आखिर में
जी
कंक्लूड करेंगे इंशाल्लाह।
जी
जी सर।
मैं कमेंट्स भी करता हूँ. इट मे टेक few minutes. I mean, I think there are quite a few issues. I think एक तो ये कि बिलाल has asked a question के would joining hands be something, and I think Pakistan Cardiac Society has already taken an initiative, and I think 2nd 3rd March को we are having a multi-society conference जिसमें हमारी 14 पाकिस्तान कार्डियक सोसाइटी मिलाते हुए 14 सोसाइटीज हैं. Professional medical societies will be at one platform to discuss cardiometabolic thing. Cardiometabolic kidney syndrome जो है, I think that's something which is the new term which is now being used. अब जो पोटेशियम का जहां तक वो ताल्लुक है, तो आई थिंक क्वेश्चन को अगर मैं इस तरह आंसर करूं कि एक क्वेश्चन डेफिनेटली आई थिंक वेरी क्लियर दैट रिड्यूसिंग सोडियम इनटेक इन योर डाइट वुड लोअर ब्लड प्रेशर. आई थिंक कितना लो सोडियम करना चाहिए उसमें कुछ डिबेट है, बट देयर इज नो क्वेश्चन दैट लोअरिंग सोडियम हेल्प्स रिड्यूस ब्लड प्रेशर. द क्वेश्चन दूसरा ये है कि क्या जो आपका सप्लीमेंट्स होते हैं सोडियम बेस्ड सॉल्ट के बजाय अगर आप पोटेशियम बेस्ड सॉल्ट यूज करें तो क्या उसका आपकी डाइट में कोई फायदा है. आई थिंक दैट वाज बेसिकली द क्वेश्चन. इसमें जितनी ज्यादातर स्टडीज हैं उसने कोई डायरेक्टली इसका बेनिफिट नहीं दिखाया. 2 years back there was a study which was again I think unfortunately industry led study, तो उसमें there was some benefit as far as the hypertension outcomes are concerned. लेकिन जो कंसेंसस है वो ये है कि पोटेशियम अपनी डाइट में पोटेशियम कंटेनिंग फूड ऐड करना बेनिफिशियल है. इसलिए फ्रूट्स एंड वेजिटेबल्स को जो ऐड करते हैं, और जो रिकमेंडेशन है कि एटलीस्ट 5 portions ऑफ फ्रूट्स एंड वेजिटेबल्स शुड बी इंक्लूडेड इन एवरी डेज डाइट. बट अगेन आई थिंक देयर इज अ मेजर इशू कि हम पाकिस्तान के हिसाब से इसको क्या रेलेवेंस लेके आते हैं. और दूसरा एक मेरा ख्याल मैंने क्वेश्चन देखा था कि पाकिस्तान के हिसाब से कोई रिस्क रूल बन रहा है या नहीं बन रहा. तो देयर इज अ स्टडी विच इज गोइंग ऑन, एंड आई थिंक इन couple of years, मेरे ख्याल 5 years में we will have validation of our own risk score as well. But until at that time, जो फवाद ने पूछा था, I would encourage everyone to start using Prevent, PREVENT, AHA का जो कैलकुलेटर है, because it is for our population global use के लिए है, और 30 से 80 years तक की एज तक है, तो इसलिए हम उसको wider range में यूज कर सकते हैं. Thank you.
President Pakistan Cardiac Society, Mahmood Saab, kindly conclude the session. जी.
I just want to thank you, Dr. Khawar Kazmi साहब. वो जो आपने स्टडीज के हिसाब से आंसर किया है, it will really मुझे भी बहुत इंफॉर्मेशन मिली है. Thank you, sir.
जी महमूद साहब.
Thank you very much. माशाल्लाह, it was the first webinar जो कार्डियक सोसाइटी के प्लेटफॉर्म से हमने शुरू किया, and it will continue till the November and then Dr. Bilal and new council will then take over इसको. हमने पिछले साल भी इस तरह हुआ था और सुहेल अजीज साहब के दौर में, तो बड़ा अच्छा इनिशिएटिव था, अप्रिशिएट हुआ था. गिव न्यू इनसाइट और इट वाज वेरी गुड प्रेजेंटेशन. बट समी साहब के पास ये प्रॉब्लम है कि वी डोंट हैव आवर लोकल डेटा. लास्ट काउंसिल की मीटिंग में हम यही कह रहे चाहते थे कि जो काउंसिल के चेयरमैन हैं उनको यही टास्क हवाला करना चाहते थे कि आप हमें लोकल डेटा प्रोवाइड करें, लोकल डेटा पे काम करें, एंड देन वी कम विद सम लोकल गाइडलाइन. एटलीस्ट मतलब कहीं से स्टार्ट लेना पड़ेगा कुछ ना कुछ तरीके से, और हमें अपना ज़ाती का वो जो है हमारा पाकिस्तान कार्डियक सोसाइटी की तरफ से अगर हम कुछ कर सकें इन द फॉर्म ऑफ कैलकुलेटर, प्रिवेंट कैलकुलेटर AC वो उनके लिए है. आई डोंट नो कि WHO का कैलकुलेटर वो हम पे अप्लाई होता है कहीं होता है, बिकॉज हमारी डाइटरी जो हैबिट्स हैं और डाइट का जो हमारा जो है वो टोटली डिफरेंट फ्रॉम द वेस्ट है, और लाइफस्टाइल बहुत डिफरेंट हो गया पिछले 30-40 साल में. स्ट्रेस बहुत ज़्यादा हो गया और काफ़ी चीज़ें हैं जो नई चीज़ें आई हैं लाइफ में इसकी वजह से. तो आई थिंक वी शुड वर्क ऑन आवर लोकल डेटा. मेरे ख्याल में कुछ स्टडीज़ हैं बहुत ज़्यादा पाकिस्तान में जो कि लोकल जर्नल्स में पब्लिश हो चुकी हैं. पाकिस्तान के अंदर जो स्टडीज़ हुई हैं रूरल एरियाज़ में भी हैं और सब कुछ अर्बन एरियाज़ में है, रिस्क फैक्टर्स के हवाले से पाकिस्तान के अंदर मौजूद हैं. अगर उसको हम इकट्ठा करें, उसको कुछ देखा जाए, एटलीस्ट हमें कुछ आइडिया मिल जाएगा, मतलब एक कि हमारे पास क्या पैटर्न आ रहा है हमारे रिस्क फैक्टर के हवाले से, BMIs के हवाले से, कोलेस्ट्रॉल के हवाले से, हमारी एवरेज एज जो है उसमें कितनी एज में हमारे हाइपरटेंसिव लोग हो जाते हैं, एंड देन MI के जो पेशेंट है हमारी एवरेज एज अराउंड अबाउट मेरे ख्याल में 50 ईयर्स है मीन एज जो है, तो वी कैन कम विद सम डेटा एंड सम लोकल गाइडलाइंस। ये लास्ट टाइम अभी हम यही कोशिश कर रहे हैं कि काउंसिल में जो भी है ज़्यादातर हम कोशिश करें कि लोकल डेटा कलेक्ट हो और गाइडलाइंस हमारे पास लोकल आ जाए, तब हम कुछ कह सकेंगे। अदरवाइज हम जो वही पुराने जो सोसाइटीज़ के उनके कैलकुलेटर और गाइडलाइंस लेके उसको थोड़ा हम चेंज करके थोड़ा मॉडिफाई करके हम लोकल बनाते, वो जो कि अच्छी बात नहीं है। अभी रियली हमारे पास हमारा रोमेटिक हार्ट डिजीज़ का डेटा नहीं है पाकिस्तान के अंदर, जो कितनी बड़ी पॉपुलेशन है। तो इंशाल्लाह वी विल वर्क ऑन दैट, एंड cardiac societies with us, with the preventive council and with the other scientific council, jitni bhi help ho sake, and we will go forward and move ahead, inshallah. Thank you.
Thank you so much, sir. So we will end the session over here, and we'll be back soon in the next program. Thank you. Jazakallah khair.